A very good evening, everyone. This is your host, Dr. Aditi Nanda, warmly welcoming you to today's webinar. The news has spread far and beyond. The World Implant Expo is already the talk of the town, and the major reason being the startling lineup of luminaries. And today, we are honored to have amongst us one of those 27 precious gems of the World Implant Expo, Dr. Yazad Gandhi. So let me very humbly and wholeheartedly invite you on DentistChannel.Online.
Thank you so much, Aditi, for the warm welcome.
Thank you, sir. So you are a name well known in the dental world, but I would still never miss an opportunity to speak a few words about you. Dear audience, Dr. Gandhi is a trailblazer in the specialty of oral and maxillofacial surgery. He practices in Mumbai and is precisely trained for endoscopic sinus surgeries. He's a fellow and registered speaker of the ITI, a fellow of the International College of Dentists, and a fellow of the International Congress of Oral Implantologists. He's an opinion leader for BioHorizons, Medese, and Gislich. He has conducted numerous CDE programs and workshops under the banner of Fusion Education, an organization that conducts CDE courses for dental surgeons across country. He has several national and international publications to his credit and even remains on board as a reviewer and section editor for multiple international journals. Sir, it's an absolute honor to be enlightened in your presence, and I once again welcome you on DentistChannel.Online.
Thank you, Aditi.
Thank you, sir. We are eager to hear from you, and our audience may know that they can put in any queries that they might have in the Q&A box given below. They shall all be addressed by sir himself in the end.
Okay. So, is this visible to all?
Yes, sir. It's nicely visible.
Okay. Good evening from India. I know there are different people from varying time zones. So that's why I say good evening from India. It's 8:30 right now. Thank you, Dentist Channel, and thank you, Smile USA Academy. We look forward to this November conference, which is troubleshooting in implant and converting implant failures to successes. And thanks, Aditi, for the warm welcome. The topic which I would like to discuss today is bone biomaterial selection and barrier selection, because there's a lot of cloud out there, and there are a lot of false facts which are going around. So I will try to separate the myth from the fact today. At the outset, this is a disclaimer slide. I am a KOL for certain companies, but please be aware that just because I am speaking for these people, that does not mean that some of the cases which are shown over here have any bias. When we talk of bone grafting, we go way back, 1600s, when Jacob van Meuken, a Dutch doctor, did the first animal bone transplant. So it may surprise some of you. We always have grown up learning that, the gold standard was autogenous bone. But in fact, the first was animal bone. And if we go further back in history, in the Mayan population, it was actually ivory, which was used to bridge gaps in the mandible. So the first bone was animal bone. It took another 150 years before the first autograft was done in Germany. So when you look at the evolution of bone grafting from 1600 till the 2000 where we are today, so the surprising fact is that we started with animal, then we moved to autogenous, which was considered the gold standard. In some cases, I still consider autogenous as the gold standard today. Then we came on to synthetics. And now today we realize that there is no one bone graft which can be called as a perfect biomaterial. So we like to mix and match for our cases. I always say this, please control your outcome. I get referrals for a host of cases which have gone south, that you go to Dr. Yazad Gandhi, he's the biomaterial fellow, so he'll set it right for you. I'm sorry. If your fixtures are placed outside the 3D comfort zone, outside the bony envelope and the soft tissue envelope, no matter who you send your case to, they cannot set it right. I am here to do science for you. I'm not here to perform magic for you. I can't do this. So you have to remember that everything comes with its caveat. basic in the bone augmentation. Simplest, which is augmenting a socket. Then we look at augmenting the ridge, whether it is in the vertical direction or it is in the horizontal direction, or it's a combination. Then we look at the sinus. There are two basic approaches to augment the sinus, lateral and transversal, and everything else is just a variation of these two. And we can always look at augmenting peri-implant bone loss because of peri-implant mucositis or peri-implantitis. So why do we augment? We can augment to correct the deficit prior to implant placement, obviously, because there ain't enough bone to place your fixture. Or you can augment alongside implant placement, as you will see from some of my cases, because you have just about the borderline sufficient to get primary stability, or you can come back and augment post function. I had posted this on my social media platform a couple of months ago, if I remember correctly. Both these fixtures have been placed by me. Don't be shocked. I have placed both these implants. Now, the one on the right looks near perfect, okay? And these scans are approximately 9 or 10 years post-loading. The one on the left looks shockingly outside the envelope of bone. So the point is, way back then, we did not understand bone biology that well. We did not understand that if bone is less than 1.5 millimeters, it will slip away. We did not understand what to graft our sockets with. We did not understand that it's not only the inside of the socket which needs to be grafted, it is also sometimes the outside of the socket which needs to be grafted, and with something different, not with autogenous bone. And this is why we end up with our own cases looking at it 10, 15 years down the line when they look at like this. Decision making when you graft depends on morphology. This has been taken off Michael Picos's book, which is a wonderful read. I urge you to pick it up and go through it. It has everything related to bone augmentation. And this I've purposely put this here because when you are a newcomer and looking at grafting bone, please pick up defects which are well-contained defects, defects which are concave in morphology, defects which have certain walls to support your biomaterials. Don't try and be the James Bond of bone grafting and pick up a vertical graft as your first case. When you look at timing of bone grafting for simultaneous fixture placement or for delayed or staged fixture placement, it's very important. And why is it important? Does timing affect the choice of biomaterial? Absolutely. Today, you come to me, I need to graft your socket. You need to come back to me for a fixture placement after 3 years. For whatever reasons, you don't stay in the same geographic locales or whatever. So if you're coming back to me after 3 years, obviously, if I just use autogenous bone, I will not have left enough hard tissue to place your fixtures when you return to me. Now, take the other option. You come to me, I need to graft your socket, and you must have a fixture placed in that grafted socket before 4 months because you are traveling long term. What would I use then? Would I use a xenograft? Absolutely not. I would obviously use something which has the fastest possible turnover. So we need to know and we need to understand why we want to pick up X from Y. We also need to understand how bone behaves the moment you pull out a root. So there are numerous studies right from 2011. There are some studies even which go back to 1996. The first, of course, was Dan Linde, which uses 50% during the first year, which is significant. And the facial bone wall thickness in the anterior maxilla in 90% of our cases is less than 1 millimeter. Now imagine if it's less than 1 millimeter and is going to go away, and you will have a vertical loss of up to 62%, and you will have a horizontal loss of up to 50%. Where does that leave you? Obviously, that leaves you with a situation that you will not have enough hard tissue to place your fixture. And remember, bone and soft tissue are married hand in hand. Bone goes away, it will reduce the soft tissue. And please, the very important fact which everybody needs to make a note of is immediate implant placement does not, I repeat, it does not prevent bone resorption. This is the biggest myth which goes around town, that you place in a fixture immediately after removing a tooth and there will be no bone resorption. I am sorry, that is not true. Immediate implant placement, in fact, if you go as per the 2013 ITI consensus, is indicated only in thick wall phenotypes, wherein your facial wall thickness is more than 1 millimeter. Look at this. This is one of my cases. Now, do you think that this case, when it was referred to me, Do you think that I was out of my mind to promise him an immediate implant? Absolutely not. No matter what the person desires, you as a clinician has the right to explain biology to him, to explain the optimal procedure to him, to explain the optimal protocol to him. So this patient went ahead with a rich preservation and when we successful results of biomaterials, what influences the success of a grafted area? The regenerative potential of the recipient site. If you send me a maxillary area to graft, I'm much more comfortable compared to the anterior mandible. The anterior mandible is horrendous as a site. You have a thick cortex, the vascularity is compromised. Then the defect size and morphology. And remember, the defect size and the regenerative potential always go hand in hand. Then comes patient comorbidity. What are the other factors from the medical perspective? Then what is the expected longevity or longevity of your rehab? I would look at a rehab from the point of view of at least 30 years in a younger individual. What is the predisposition towards periodontal or peri-implant disease? There are so many cases today that we see on social media. Horrendously periodontally involved teeth pulled out, immediate implant placements, full mouth, patient goes ahead with your restorations, immediate loads. Remember, the perio microbes do not immediately vanish the moment the root is pulled out. They will affect your results. How do we classify our biomaterials? If I am to take the liberty to broadly classify it on the basis of two platforms, I will choose it to be classified as according to the physical form of your biomaterial, what you get it as, how it's provided to you, and what type of biomaterial it is. So when you talk of physical form, how does that affect you? Because physical form is important. Why? It determines the applicability of the biomaterial. It determines how well or how poorly you can adapt it, how stable it is going to be at that site, whether you need a carrier to take it from the table to the mouth. What are the resistance to physiologic forces? Because it's in the oral cavity. Obviously, you can't tell the patient that he doesn't need to chew on that side for 4 months, not possible. And whether you need a barrier or you don't need a barrier. Then come to biomaterial type. When you talk of the type of biomaterial, it determines your turnover time. How soon can you re-enter for a delayed or a staged fixture placement? What are the costs involved to you and, of course, to the patient? What is the indication of using that particular type? Whether you want a faster turnover or you want a slower turnover. And I don't know about the rest of the world, but in our geographic locales, we do have a particular religious bias wherein certain people from a sect do not want a particular animal source biomaterial used. So we have to take care of that. So when you talk of properties of a graft, what are the properties of a graft? Three properties, which are osteogenic potential, osteoinductive potential, and osteoconductive potential. Osteogenic means the graft itself supplies you with viable bone-forming cells. Osteoinductive means it kickstarts the mesenchymal cells to differentiate into the bone-forming osteoblasts, and whereas osteoconductive means the graft just acts like a matrix or a lattice or a framework onto which your own bodily cells form bone. When you look at autografts, there is pure osteoinductive and a little bit of osteogenic potential. When you look at allografts, there's a little bit of osteoinductive potential and more of osteoconductive potential. When you look at animal source bone and synthetic bone, you have mainly osteoconductive potential. It just acts as a mere lattice. So we need to understand this very clearly before we pick up our bone. Look at this. This tells you that the market is flooded. Almost every month, we have some or the other rep knocking at our door that, please take this biomaterial. This is the research, that is the research. Remember, when you go through research, please do not jump to the conclusion of the abstract. I have seen the best of clinicians, when they go through research, they look at just the abstract. They look at the conclusion of the abstract, which is worse. You've got to look at the inclusion and the exclusion criteria when you look at journal studies, because that is what will point you what biomaterial you should fit into which category of patient. When you look at block, you can have an allogenic block, you can have a animal source block, you can have your autogenous block, you can even use IPRF to formulate your own bone steak or bone carpet, as they call it. So when you talk of autogenous bone, it has remained the gold standard, obviously, excellent osteoinductive potential, some amount of osteogenic potential, good quality bone, but it comes with its own set of morbidities. You need to harvest it. Allogenic bone, basically open a bottle, expensive, longer turnover time, but no donor site morbidity. When I talk of allogenic bone or allografts, let me clear the air. There are people who are still confused. What is the difference between FDBA and DFDBA? The D stands for demineralized, as simple as that. When you have your freeze-dried bone, the moment you set it through a demineralization process, it turns to DFDBA. So FDBA, because it has mineral content, it resolves slower. DFDBA resolves faster. Because the mineral content has been removed, there is more expression of BMPs in DFDBA compared to FDBA. Then talk of animal source bone. Again, open a bottle, peel a pack protocol, simple. They are expensive. Good quality bones are expensive. And the quality of bone formed is not as good as autogenous bone. If you're looking at a turnover rate for maybe 4 to 5 months, you will still have residual graft particles. And in fact, our group, we published that porcine xenografts are a good substitute to bovine xenografts, and they may expand the clinician's choice of bone grafting biomaterials. When you talk of xenografts, there are two available in the market. Either you choose the hydroxyapatite or you choose the carbonate apatite. The difference is just in the terminal ion. So you have the OH minus ion or you have the CO32 minus ion, the carbonated ion. The difference being that if you choose carbonate apatite, it is turned over much faster. So the slide on your left of the screen was grafted with autogenous bone and carbonate apatite. You see almost a near turnover into good bone at 6 months. And the slide on the extreme right was sintered hydroxyapatite, which is heat-treated hydroxyapatite, which is extremely slow resolving. So we need to keep all of this in mind, because if you re-enter and you find gross bone particles like this, that's not the ideal scenario to go in and place your fixture. Then talk about alloplastic or synthetic bone. Again, peel a pack protocol, very simple to use, mostly osteoconductive. Quality of bone is not as good as autogenous, and it disappears very fast. It gives you that feel-good factor, especially when you're using the putty consistency, because it stays there. You can form a nice dome-shaped bone. But remember, my friends, when you talk of using putty, about 29 to 30% of the putty is a gelatinous matrix which will disappear. So if you pack in 1 cc of putty bone, do not think that you will end up with 1 cc of bone, because about 30% of that is going to disappear. How does particle size influence your outcome? Particle size influences the adaptability, how well you can contain and adapt your graft to the defect, how well it is retained to that area, what is the vascularization of the entire matrix which is going to happen, injury to adjacent anatomic structures from sharp particles which may happen, how fast or how slow is your turnover, and your volume maintenance. So this is a very good publication in 2005, which says that larger particles are better in a closed box unit, for example, a sinus graft. What is the logic? Better volume maintenance, okay? You have better vascular fill because the spaces between the larger particles is more. Retention is not an issue here, so you aren't concerned. And you can get more by putting in less. Smaller particles, better in a horizontal and a vertical ridge augmentation. What is the logic? It's simpler to adapt to the host bed, better to retain, easier to handle, and the turnover is faster in those areas. Why? Because remember, each particle starts the turnover by kickstarting the turnover close to it as in a million nuclei, small nuclei, compared to maybe 1,000 nuclei in a larger graft. Then talk about barriers. When you have particulate grafts, obviously you need a decent quality collagen or a PTFE barrier. When you look at resorbable barriers, again, the market is flooded. There are barriers which will disappear in 2 weeks. Would you think that I would be using that? Absolutely not. I would want a barrier at least to remain there for 8 to 12 weeks, because that is the minimum which you need for bone formation. You have barriers which are pliable, you have barriers which are space maintaining, and they are pretty much rigid, need to be fixated. So what is the difference? Initially, barriers, the resorbable ones, were thought to just act as scaffolds, but now we understand that some amount of cellular activity has been seen around them. They have been known to attract platelets. What do they come from? They come from mainly type 1 and some from a mixture of type 1 and 3 collagen. The source is bovine tendon, porcine dermis, porcine pericardium or peritoneum, and even the equine source is there. Native barriers are much more flexible. They are hydrophilic. They have more tear resistance, but they resorb fast. The cross-linked ones, they stay longer, but they have decreased permeability. Cross-linkage can be done by UV light, glutaraldehyde, or enzymes. The tissue adaptability of a native barrier is far superior, being more hydrophilic. So you tell me, which is the ideal barrier? I would definitely want to pick that up tomorrow morning. Is there an ideal barrier? Do we still have an ideal barrier? Absolutely not. I wish we did. And if you do know of this barrier, which has all these 6 prospects, please, tomorrow you can share it with me over email. The ideal barrier should be biocompatible. It should have good tissue integration. It should have dimensional stability. It should have good handling. It should have selective permeability, and it should decently maintain the space. It's impossible to get all 6 in one. So you as a clinician need to choose where you want to pick up what. So I've tried to delineate these two, native versus cross-linked. Where you want higher tear resistance, go for native. You want a less flexible barrier, go for cross-linked. You want better adaptability, go for native. You want better space maintenance, go for cross-linked. You want better transmembranous porosity for vascular perfusion, pick up a native barrier. You want slower tissue integration, and you are ready to fixate it in most of your cases, go for cross-linked. You want the barrier to go away faster, and you want a hydrophilic barrier so that you don't want to secure it, pick up a native. You want it to resolve slower, you pick up a cross-link. As simple as that. Then come to your PTFE barriers. There's a lot of confusion today. Earlier, we just had ePTFE or expanded PTFE, the outer layer of which has some amount of porosity. Now we also have DPTFE or dense PTFE. So what is the difference? The amount of regeneration shown in various clinical studies is almost equal. There is not much of difference. The difference is that DPTFE doesn't have the outer porous layer, so it's very simple to remove. The ePTFE, because of the outer porous layer, the collagen fibrils tend to infiltrate. So literature has hypothesized that it gives you better stability during the healing phase. But remember, ePTFE or DPTFE both have a notorious potential to get exposed. Now let's talk about a couple of cases. When you talk of dual layer grafting in aesthetic zone, what do you mean dual layer? This is a socket graft with an immediate type 1 placement. We need to graft inside the socket, and I will also graft outside the socket between the periosteum and the facial bone wall. Why? Remember the slide that I told you? 90% of your cases have less than 1 millimeter of the facial wall. What happens if that disappears? Where does that leave you? So I will graft inside the socket with a fast resorbing graft, my preference autogenous, otherwise allogenic. Facial to the socket wall, I will always prefer xenograft. So this is the result at 6 years. It gives you a beautiful volume maintenance of hard and soft tissue. Then you may have complex sockets. If you look at this, a young lad who came to me, dilacerated root, there is no hope in hell that I can get this tooth out without sectioning the root. So what do? We end up with a remote incision. We don't want to disturb the papillary architecture here, because we all know from literature that the moment you lift the periosteum of the papilla, you lose 0.5 millimeter of bone. Here we used a mixture of cortical shavings used with a wonderful instrument from Geitlich, which is the micros, mixed it with xenograft, used a native collagen barrier, and closed everything up. At 5 months, you have a sufficient bone gain. You place your fixture, you temporize it. The prosthetics is just the same for everything. And at 2 years, you have a wonderful outcome. I'll share this paper that we published in 2015, if I remember correctly, in Clinical Oral Implants Research, wherein we used autologous cell culture. We extracted human osteoblasts from the posterior iliac crest marrow, and we used it for maxillofacial bone tissue engineering. The short little case which I will share with you, it has a small little video clip. This was a young lady. This is post a road traffic accident. She lost most of her premaxillary bone. She lost all her mandibular anterior teeth and the labial cortex along with that. Now getting from point A, which is almost a knife edge ridge of 1.5 millimeters, to point B, which is a ridge of about 9 millimeters to 11 millimeters, is pretty simple when you use something like osteoblast culture. So just have a look at this video. So this is the kind of bone that you can generate with osteoblastic harvest. It behaves pretty much the same as RHBMP2. So when you talk of complex defects, these are thrown in your face, and if you do not have the requisite skill sets, then you will land up facing some amount of complications. This case was actually referred to me that go to Dr. Gandhi, he'll do a sinus lift for you. My friends, this is not a case for a sinus lift. The bone has been lost in the inferior vector. It has been lost in the vector which is below the basal bone level. It has not been lost in the superior vector. If I do a sinus lift here, the fixture will be placed in the wrong location. So you have to remember how to tackle these cases, otherwise you will land up with complication. And when we talk of complications, this is the exact conference which you guys need to sign up for. So this November, no matter which road you take, I think all roads are going to point to Kochi for the World Implant Expo 2023, where a host of clinicians will be talking of complications. I will be salvaging failure augmentation, because when you talk of sinus augmentation failures, I've seen it all. We've even ended up removing a fixture which was stuck to the inferior cortex of the orbital floor. So see you in Cochin. Let's come back to this case. So talking of this bipolar defect, as I term it. Why is it bipolar defect? Because there's a defect superior and inferior. So if you do not graft the inferior pole, where does your implant land up? Your implant lands up where you see it on your screen. So you have a 10 millimeter long implant and you will have a 24 millimeter long crown. That is going to become a periodontist nightmare for maintenance. So what do? You actually graft the bone which is lost in the socket area and you place your fixture at the correct area. So what do? I convert an FP3 defect into an FP1 defect. This is the amount of bone which is achieved. So once you achieve this amount of bone, then you are sure that you place your fixture in the correct prosthetic position, because that is what a patient has come for. So now you see that at 5 years, what we gained and what we achieved is there to stay. We started from almost a millimeter and maybe 1.4 millimeters, less than 1.5 millimeters. It was just an eggshell. Take another case, ridge augmentation. Patient comes with kind of a faulty restoration, if I may term it so. There's one monocortical implant and it's been bonded to a natural tooth. Everything has failed. So because of which there's also some amount of labial bone loss, which has taken away the bone. Now, when this entire unit fails, you need to stage the procedure. So I always walk on the gray line. I end up telling my patients that, look, I will keep everything on standby. If we get enough primary stability, placing your fixtures in the prosthetically desired position, therein we will go and do an immediate placement and a simultaneous graft. Else we will abort the placement and we will just do the graft. But luckily, we did get primary stability. So we placed 2 implants, and here we use a layered particulate graft with IPRF, autogenous bovine with your native. You get good regeneration, and a 7-year follow-up shows you excellent cortical bone stability along with soft tissue stability. So remember, you build the bone which is there to stay, the soft tissue will follow. Again, a case which shows you contour grafting. When your implant is placed and you see that the implant stretches the cortex to the limit, you can actually see the gray hue of your titanium. This is not going to stay. This bone is going to melt away. So would you as a clinician want to use autogenous bone here? No. Would I want to use allogenic bone here? No. I will use something which is delayed resolving. So we end up using carbonate apatite here. You get a wonderful result. Restoration of optimal contours looking at where we started from. So you choose your biomaterial correctly, your result will follow. When we talk of spontaneous bone fill in your sockets with immediate placement, there is a term which is commonly misused. I see it very commonly misused on social media. People end up saying, "Hey, I grafted the jumping distance." I'm sorry, you are absolutely wrong. You never graft the jumping distance. You always end up grafting the non-jumping distance. If it is jumping distance and if the osteoblast is ready to jump that area, why in the world are you end up grafting it? You don't have to graft it. So when the jumping distance, which has been suggested as 1.5 by Schenk in 1994, does it mean that every 1.5 the osteoblast is going to jump? No. The defect morphology has to be such that it favors coagulum retention. Only then will bone fill in. Otherwise, it will not. See another case of ridge augmentation where we had to stage the protocol, a young lady congenitally missing mandibular central incisor. So we had to send her back to the orthodontist. I wanted the roots parallel. Once the roots are parallel and everything is finished from the ortho perspective, she comes back to us. Here we use the bio-collagen block along with autogenous bone. We graft the area. Once you have a nice bone fill, you end up placing a fixture flat in the center. This is prosthetically guided by your CAD/CAM stent. So therefore, there's nothing which can go wrong over here. And at 4 years, you see a decent outcome. Well, the hygiene could be maintained better, but yes, the outcome still remains stable. When you talk of sinus augmentation, what is your decision making in sinus augmentation? Which technique will you use and which biomaterial will you use? Now, does the biomaterial sometimes differ according to the technique that you use? Absolutely. There are a couple of publications which you can go through. Our group published in 2017, which is a review article, everything about sinus grafts, what it started with and what it was used up till 2017. So you can go through that. It's available on PubMed. It's a free publication. So when you talk of a lateral window, the biomaterial obviously will be different. When you talk of a crestal approach, the biomaterial will be very different. So you can go through these articles and you can understand what to use, why to use, and how to use it. Your results will follow. When we talk of extreme amounts of grafting like this, you see, we go from about 2.1 millimeters to 13.2 millimeters of solid bone formation. This is a staged approach. This is the lateral window protocol. So here, I always prefer using a mixture of autogenous bone and xenograft. In this particular case, the lady completely refused that no bone will be taken from my body, then fine. I don't have a choice. We have to use a mixture of allograft and xenograft. And if instead of autogenous, I am using allogenic bone, then the only difference is that I will add a month or two in the waiting period. Another protocol with a completely eggshell maxilla. This lady is in her 70s. The maxillary bone is maybe a millimeter, 1.1 somewhere, 1.7 at places. So here again, you have to remember that you need all your sections when you requisition a CBCT. Please look at your scans in every possible section, not just in one cut. So the surgical sequence to be followed here is correct your vertical deficit inside the sinus in the space that you created by lifting the membrane. Thereafter, correct your horizontal deficit which you had, adapt your barrier, fixate your barrier, and close. Remember, you've got to fixate your barrier. Anything which moves around will form fibrous tissue. Anything which is stable will form osseous tissue. This is the amount of bone fill that you get, and you're good to proceed from here. And not only do you look at the bone fill on the scans, but I always tend to flap my cases upon re-entry because I want to see how well that bone bleeds. Because that is what ends up telling you that what is the turnover of that bone. If that bone is chalky white, if that bone does not bleed upon flap reflection, that means that your turnover is not optimal as it should have been. So if I may say, what are your pointers for predictable results? Your mesenchymal stem cell recruitment has got to be there. The site has got to show adequate vascularity. The graft has to show adequate stability. As I just told you, anything which shows micromotion points you towards fibroosseous reunion. There has to be passive closure. You cannot possibly pull your flaps together with your sutures. Given 72 hours and everything will open. What is your optimal re-entry time? You as a clinician need to understand that. So because you have decided your biomaterial type depending on your re-entry time. What is the role played by the biomaterial? Are you putting it just as a scaffold? If I'm putting a biomaterial only as a long-term scaffold, for example, the first case which I showed you where I was putting xenograft facial to the socket, I don't want turnover. I want it to just stay there. What is the comparative ease of handling a biomaterial A versus biomaterial B? What is the fate of the craft with time? Will it resolve after 9 years? Will it remain incorporated in the turned over tissue? What is the comparative turnover of different materials at different amounts of time? And what is the volume maintained? If I graft the sinus today for 13 millimeters of vertical height, after 11 years, will I still see that 13 millimeters or will I lose some amount of bone? Is there a clinical benefit to placing an implant in a site with significantly more vital bone? If yes, how much vital bone is needed to support a dental implant during integration? Osteotomy techniques which are sensitive with some materials. A typical example being if you've ever ended up using more of xenograft in a socket graft, please do not go ahead and osteodensify that because densification relies purely on the collagen-based plasticity of bone, which is absent in your xenograft. And what is the difference in percentage of your vital bone formed? Ongoing research on all of these topics will continue to enlighten us. So do not let imperfection be the enemy of good for your cases. And thank you one and all. You can follow me on these social media sites. Thank you for listening. Thank you for your time.
Thank you so much, sir. We just got a glimpse of the wonders you have been performing in the field of dental rehabilitation. Thank you for enlightening us with your wisdom and for being the torchbearer for young dentists like myself. And we appreciate you sparing your invaluable time for us today.
Thank you.
So, before we conclude, any concluding note from your side for aspirants interested in visiting the World Implant Expo?
So the aspirants who are visiting the World Implant Expo, I am sure that they will take home a very, very important message of what not to do where. Because when you look at learning complications, when you look at learning what not to do, it's more important when you learn what not to do rather than what to do. If you've got it right where not to burn your fingers, your complication rates come down. So I would definitely urge all the youngsters who are placing implants to please come there, please attend the conference, because not only from the surgical perspective, but also from the prosthetic, from the treatment planning, from perspectives as simple as lab techniques, there is everything which goes hand in hand in building that optimal case.
Thank you, sir. So, if you may allow, I would like to share the eclectic array of luminaries that are coming to the World Implant Expo with our audience.
Yes, please. Yes.
Thank you, sir. And just like that, in God's own country, we are bringing you the finest of dental conferences, the World Implant Expo, from November 26th to November 28th at Le Meridian, Kochi, Kerala. And here's the lineup of the greatest minds and hands of dentistry. Registered at the earliest to aware our limited time period offer, and stay tuned at worldimplantexpo.com for further insights of the World Implant Expo. Thank you so much. Thank you once again, Dr. Yazad. It was an honor to learn from you. Thank you so much, sir.
Thank you. Thank you. Bye-bye.
Bye.